special greeting to you, Dr. Wilhelm. Please begin your presentation.
All right, thank you for starting me off. And I will just get started with my disclosures. So I received some research support from the International OCD Foundation, and I have received some funding from the Tourette Syndrome Association. I also received speaking honoraria from both of these associations, and then I received some royalties for publications on Tourette's and OCD. Okay, and here is what we will be covering today. So I'll get started by talking about the evidence for behavioral therapies for tics and OCD. Then I'll actually show you how to conduct the comprehensive behavioral interventions for tics. And last but not least, we are going to go over how to conduct cognitive behavior therapy for OCD. So let's get started with the evidence for behavioral treatments for tics. And Dr. Pasentini already mentioned it briefly. There's a treatment that's called habit reversal. That's basically a behavioral treatment for tics that has been around for a long time and has initially been studied in smaller scale studies. And I just want to show you its components. So the core components are those that are bolded here on this slide. So first, there is awareness training. Awareness training means that you have to make your patients very aware when a tic is about to occur, because of course they can only prevent a tic from happening if they really know that it is occurring. And the second component here, that's also a really important core component of habit reversal, is a competing response procedure. That means that you are teaching your patients to engage in a behavior that's actually physically incompatible with a tic, so it prevents a tic from occurring. So these are the two core strategies, and there are some additional strategies that you may also use with your patients, as relaxation, of course, social support, and motivational strategies. And in the recent past, there were two very large-scale studies that investigated behavior therapy for patients with tics. And those studies included habit reversal, but also some other components, which I will be covering shortly. So the first study here is a child study. That was a study with 126 kids. And the second one is the adult study that included 122 teenagers and adults. And as you can see here, those studies were conducted at 6 different sites. So there were participants really from all over the country who participated in this research. And here is what we actually studied. So our behavioral treatment, our cognitive behavioral intervention for tics, included psychoeducation. That's where the patients learned actually many of the things that Dr. Pasentini already covered this morning, you know, about the prevalence of tics and their natural history, common comorbidities, and so on. And then habit reversal, which I just gave you a quick overview of, and then function-based interventions. We haven't talked about that yet. That basically means that you help your patients detect antecedents for tics. So these are things that happen before the tics, and as well as consequences. These are things that are happening after the tics. And then you basically try to modify anything that makes tics worse in the service of tic reduction. And then last but not least, CBIT also includes relapse prevention, of course, in order to help your patients hang on to the gains, to make sure that they can hang on to the treatment gains. And that treatment was compared to psychoeducation and supportive psychotherapy. And here's what we found. So this slide here shows you the responder status at after 10 weeks of treatment in the child study. And responder status in this study was assessed with the CGI. That's basically a measure where patients rate themselves as improved or not improved. So what you can see here is the patients who rated themselves as either much or very much improved. And the dark bar here on the left, that's our behavioral treatment, that's CBIT. And the somewhat lighter bar on the right, that's our supportive psychotherapy treatment. And you can see that those patients in CBIT actually did quite a bit better. So 52.5% of the patients who participated in CBIT rated themselves as much or very much improved, and only 18.5% of the patients who participated in psychoeducation and supportive psychotherapy. So that was encouraging. And here is just another way of looking at the same data. So here we are looking at the data that we collected with the YGTSS. That's basically a measure that assesses tic severity. And on the left, you can see our baseline data. You can see the data pre-treatment, right? And on the right, you can see how they did at endpoint after 10 weeks of treatment. And you can see, again, the dark bar is CBIT, that CBIT led to a significantly greater decrease in terms of tic severity as compared to our control treatment. So these are the child data. Let's take a look at the adults. And once again, we are looking at the responder status. So once again, these are the patients who rated themselves as very much or much improved by the end of treatment after 10 weeks of treatment. And you can see that the patients in the CBIT condition are doing better than the patients who got supportive psychotherapy and psychoeducation. But you might have also noticed that the data are not quite as good as what we had seen in the child study. And if you recall, Dr. Pasentini talked a little bit about that. He said that for many patients, tics may improve or they may even completely go away as they reach adulthood. So that might help us understand a little bit what we are seeing here. It's perhaps possible that those patients who are still stuck with the tics in adulthood might have a more chronic or a more severe form of the disorder. And I also want to show you the results on our tic severity measure. Again, this is the YGTSS, the Yale Global Tic Severity Scale. And of course, once again, high scores mean that the tics are severe. And on the left again, you see the baseline data. And on the right, you see what happened to the patients by the end of treatment. And once again, you can see that CBIT was associated with a greater decrease in terms of tic severity on this measure. So, I mean, these data are pretty encouraging. These are pretty large studies, and clearly they indicate that CBIT is more effective than supportive psychotherapy. What was also nice to see in those studies was that the treatment gains were durable. So the majority of the patients who responded showed continued benefit even 6 months after the end of treatment. And it seems like that the treatment was acceptable. So attrition was low. So once patients started it, they were likely to stick with the treatment. And what was also nice to see was that the symptom severity reduction of this treatment was similar to what we find if we treat patients with antipsychotics. And now I want to switch gears a little bit, and I want to talk about the evidence base for cognitive behavior therapy for OCD. And behavior therapy, and actually a specific form of behavior therapy called exposure and response prevention, has been considered the gold standard psychotherapy for OCD. So exposure basically means that you are encouraging your patients to go back in situations that they would otherwise avoid or that they only endure with high anxiety because of their OCD. And ritual prevention or response prevention, and we use these terms interchangeably, means that you are discouraging your patients from engaging in rituals during these situations. And what we have seen over the last few years is that behavior therapy is increasingly enhanced with cognitive interventions. So in cognitive interventions, you basically get your patients to examine their thoughts in terms of their validity, how valid are your thoughts, and also in terms of their usefulness, how helpful are these particular thoughts. And what we see more and more in clinical practice is that cognitive and behavioral interventions are combined, but they're also often enhanced now with mindfulness and acceptance-based interventions. And I will be covering all of those today. And not surprisingly, what you also see is for the more severely ill patients, you see often a combination of cognitive behavioral interventions along with pharmacotherapy. So now I want to show you a slide on the outcome of exposure and response prevention as compared to other treatments. And what you can see here is a measure of OCD symptom severity. The Y box is our gold standard measure of OCD symptom severity. And of course, a high score here on this measure means that your OCD is severe. And in this study by Edna Foer, a number of different treatments were compared. So the green line here is placebo, the red one is clomipramine, the sort of purplish one is exposure and ritual prevention plus clomipramine, and the really dark black one is exposure and response prevention. And what you can see here is that the patients who got placebo, which is basically a sugar pill, didn't improve very much, and all the active treatments were all better than placebo. Clomipramine was better than placebo, but was not as good as exposure and ritual prevention or the combined treatment. And as you can also see on the slide, there was really no difference between exposure and ritual prevention or exposure and ritual prevention plus clomipramine. So this was encouraging for the use of behavior therapy in OCD, and this study was done in adults. And now I show you a similar study that was done in children. Oops, now what happened? I don't know how I just got back to this slide, but here. Anyway, so now I want to show you a similar slide on behavior therapy in children. So this is a pediatric OCD treatment study, or the POD study. And here again, the sort of greenish line is placebo. That was compared to sertraline, which is a serotonin reuptake inhibitor, compared to cognitive behavior therapy. And once again, we have the combination treatment. And once again, just like in the adult study, all of our active treatments were doing better than the placebo group, not surprisingly. But what was interesting about the POD study was that the sertraline and the cognitive behavior therapy did not really differ once we assessed it with OCD Y box, right? So the combination treatment was the most successful in this study. If we looked at the data in a little bit of a different way, the remission rate for the combined treatment did not differ from that for CBT. So still results that are very, very encouraging for the use of cognitive behavior therapy in OCD. And here is just more of a big picture slide. This is a meta-analysis on CBT for OCD, just very recently published in 2013, where 16 randomized controlled trials were included. And in this study, it was shown that CBT actually outperformed all kinds of comparison groups. So again, more evidence for the efficacy of CBT. And what was also quite helpful in this study was that they also looked at moderators. They were trying to figure out who actually benefits from CBT, who are the people who should participate in this treatment. And what they found was that neither type of CBT, initial OCD severity, onset of OCD, and even comorbidity had no moderating effect. And in some ways that was nice to see, because basically what that shows us is that, anybody who starts CBT actually has a chance to improve. What was also interesting to see in this study was that the studies that were done with adults had smaller effect sizes than those that were done with children, and the effect sizes decreased as age increased. Okay. So now what I want to do is I want to switch gears again, and I actually want to show you how to conduct this treatment. I want to tell you a little bit about what you would actually do with your patients as you are getting into these treatments. And we are going to start out with our TRIC treatment, with our cognitive behavioral intervention for tics. And here's an outline of this treatment. So usually you start out with psychoeducation, then you might do motivational interventions. You might need more or less of those depending on how engaged your patient is. And then you might also consider doing function-based interventions. This is a pretty important component of the treatment. That's why I bolded it for you. Then you do habit reversal. You already learned about that. And then you may do some relaxation training as needed. And then once again, in the end, you do relapse prevention. And I'll be covering all of those components with you. Just to give you a sense of the structure of therapy, so you always start out by doing a detailed good intake assessment. Then in our studies, we usually did about 8 sessions of treatment, but you can actually vary that a little bit depending on how severe your patient is. You know, if you have a patient who's more severe, you might need more than 8 sessions. And of course, if you're working with a milder patient, you might get away with fewer sessions. You also may want to consider offering booster sessions at the end of treatment, just to help your patient maintain their gains. In our studies, the sessions were typically 60 to 90 minutes long. Again, that might vary a little bit in terms of even what's possible in your practice. And then if you're working with adults, you often might end up doing an individual treatment. But of course, if you are working with children, it's very, very helpful if parents can participate. The younger the children, the more important it is that you have a helper with the treatment. And what you'll find is as you're conducting this treatment, it's actually really fun to do. It's a really collaborative approach in the treatment, and you and your patient decide together what you want to tackle. So here's how it goes. So as I already briefly mentioned, you start out with psychoeducation. That has a lot of what we already talked about in the first module today. So as I said, you might talk a bit about the diagnostic criteria for tics with your patients. You might go over what typical tics are. You talk about what they look like, what their natural history is, what kind of social difficulties and comorbidities might be associated with them, and even how common they are. And then you move on to giving your patient a rationale for CBIT. And I usually briefly explain that we are going to do function-based interventions. So these are the interventions that reduce the factors that maintain the patient's tics or that exacerbate the tics. And then I describe also that another core component is habit reversal. And again, you probably recall that the 2 core components of habit reversal are awareness training. That's where you make your patient very aware that the tic is occurring, and then the competing response procedure, where you ask your patient to engage in a behavior that's physically incompatible with a tic. And the patients might wonder why this works. And then you go back to the premonitory urge that Dr. Presentini already described earlier. So Dr. Presentini already described how that premonitory urge is a really unpleasant sensation. And as a matter of fact, when I talk to my patients about it, they will often say, you know, this premonitory urge is actually worse than having the tic itself. It's like having an itch, and you know, I feel like I have to scratch it. So it's a very, very unpleasant sensation for your patients. And the premonitory urge goes away or is reduced when the patient tics. So now your patient feels a sense of relief, right? And the tic just got reinforced because the tic is associated with that sense of relief because the premonitory urge is gone. And in therapy, you shift gears. In therapy, your patient learns to tolerate the premonitory urge. So in other words, the tic is no longer reinforced. And what you'll find is that at the beginning, this treatment is actually somewhat effortful, but over time, the premonitory urges as well as the tics, they get weaker and it gets easier to do. And that brings me to my next topic, the motivational strategies. So as I just said, it's kind of effortful to do this treatment at first. So what do we do in order to get patients to hang in there? What do we do in order to motivate patients to do the treatments? Well, typically what we do is we do an inconvenience review where we talk to the patients about the problems that have been caused by their tics. Right, so what's unpleasant about the tics and how do they get in the way? And then we also talk about what advantages might be associated by engaging in treatment. Now, for younger patients, you need more than that. So for younger patients, you might also need a behavioral reward system. So what we typically do is we give them little prizes or little rewards like stickers, or the teenagers might want, points so that they can buy gift cards or something like that in order to motivate them to attend the session. So that's the first thing we reinforce. They basically get a little reward just for coming. They get rewarded for participating in session activities, and they also get rewarded for completing homework assignments. And what you have to keep in mind, though, is that you are rewarding them for these three things that I just mentioned. You don't want to reinforce them for tic reduction, because obviously the flip side of that would be to almost punish them for having a disorder. So you motivate or you reward them for basically participating and putting effort into the treatment, into their strategies. Next, you might conduct some treatment planning where you make what I call a tic hierarchy. So typically what I do is I have them list all of their tics, and then I ask them to rate how bothersome or how much each tic that they have gets in the way. And I ask them to do that on a scale from 0, that's not at all bothersome, doesn't get in the way, doesn't bother me, to 10, which is extremely bothersome. And once you have an overview of what the tics are like for your particular patient, it's much easier to plan the treatment. I typically start the treatment with the most bothersome tic, but not always. The reason why I typically start with the most bothersome tic is because, that's where you get the most bang for your buck, so to speak, right? It's most rewarding if you can help your patient with their most bothersome tic, and you gain a lot of credibility as a therapist if you do that. But there are some tics, like, for example, eye blinking tics or so, that are harder to treat. And in that case, you might want to start with another tic, with maybe the second most bothersome tic, before you tackle a more challenging tic. And again, as I said earlier, this treatment is very, very collaborative. So the patient or the family and I, we really decide together which kind of tics we want to tackle and in which order. I might have some suggestions, but I always run it by my patients to make sure that we are all on the same page. Okay, so next we are moving into the function-based interventions. So those have a number of different steps associated with them. So the first one would be you conduct a functional assessment with your patient. So you talk to them about the antecedents that precede the tics, and then you also talk about what's happening after the tics. What are the consequences that are associated with exacerbation of tics? And once you know that, then you develop some interventions around those. So you want to obviously minimize, or if you can, eliminate situations that exacerbate the tics. And you also want to remove anything that reinforces the tics. And you can also minimize the impact of the actual tics on the patient. So, for example, what we often do is we go into schools, for example, and we educate classmates and teachers about tics, because if you do that, others might respond differently to the tics. And anyway, after you develop the interventions, you also want to develop a plan for implementations. And next, I just want to give you some examples for what that might actually look like. So, for example, if that's a very simple example, if a particular antecedent is watching TV, if a kid gets worse in terms of their tics while they're watching TV, obviously you can limit the amount of time that they spend watching TV. or in terms of consequences, if siblings or parents or classmates even always laugh, or after somebody tics, they can be educated around that. Or what we see very often is that actually parents feel bad for their children, so they might comfort the child after the child tics. And again, while the parents mean well, this is still a consequence that could actually reinforce the tic. So in that case, parents would be told to no longer comfort the patient after they tic. Another thing that we see very, very often is that family members just tell the patient to stop the target tic, or just stop it. But again, that can make the patient very anxious and might actually have the opposite effect, in the sense that the tic might actually get worse. So if that was the case, again, that's something that you can address here in that function-based intervention stage of the treatment. So after you have done function-based intervention, you go into the habit reversal part of the treatment. And as I already mentioned, the first step of habit reversal is awareness training. And even awareness training can be broken down in a number of different steps. So the first one here is self-monitoring. And that basically means that you ask your patient to record their tics. And I usually do that a little bit differently depending on whether it's a very frequent tic that the patient is dealing with, or whether it's a tic that only occurs several times over the course of the day. I mean, if it's a rare tic, you could basically have them monitor every time the tic occurs. But frankly, most patients who are coming into treatment have much more frequent tics. And in that case, what you would do is that you would agree with the patient to maybe set aside half an hour a day. That's pretty representative for the kind of tics that your patient has. And then you would have your patient monitor during that half hour. And what can also be useful during that phase of treatment is that your patient can already start monitoring certain sequences of tics. So, for example, if you have a patient who always does the same sequence when they have a particular tic, and it always starts with a hand, and then they might move their arm, and then they might move their shoulder, so they could actually record that. So H for hand, and A for arm, and S for shoulder, if it always occurs in that sequence. And that actually brings me to the second point here, response description. So what you really want to learn during awareness training is what that tic is exactly like. What are the different components of that particular tic? What are the different parts that go into it? So, and not only what you can see and feel, but even what's happening prior to the tic. So a patient might say, oh, before I have this particular tic, I get this premonitory urge in my shoulder. So I have this tingling sensation in my shoulder. And next I move my arm, and next I move my hand, and so on. So the more detail you can get about the tic, the better. And then after you feel like you have a good sense of the tic that you want to work on, you do what's called response detection. So that now basically means that you're asking your patient to detect their tics. So what I often do with my patients is we do what we call, fake talking or talking. So in other words, my patient might be telling me a story. So for example, if they went to a soccer game on the weekend or so, they would be talking about that. And their job is to engage in a conversation with me, but at the same time, they're also required to detect whenever they are ticking. So we are talking, and if the patient tics and the patient acknowledges it, that's good, and I praise the patient. And if we are talking and the patient tics and just kind of keeps talking and doesn't acknowledge that they just ticked, I prompt the patient. I said, there was a tic, and let's just keep going. Let's keep trying that. There are different ways in which they can acknowledge their tics. I very often just have them lift a finger whenever they are ticking, so that I know that they have noticed that a tic just occurred. And we practice this for a while. So usually we keep going until they're about 80% correct or so before we move on to the next stage of awareness training, which is the early warning procedure. So far, you only asked your patient to detect the tic when when it was actually occurring. And really what happens is that they detect it while it's happening, or sometimes they only detect it a little bit after the tic already happened. And what you want to do next is that they already detect the tic during the premonitory urge phase. So in other words, what you want here is that they detect the tic already at the earliest warning stage. And that makes sense because if they are actually realizing that they're about to tic but not ticking yet, then they can prevent the tic from occurring, which is your ultimate goal. So after you have practiced awareness training, you're moving on to the next phase, which is the competing response. And there are three rules that you want to keep in mind as you are choosing the competing response. The first one is that you want to pick something that is actually incompatible with the tic. You also, so something that makes it hard for the tic to occur, basically. You also want to think about something that's less socially noticeable than the tic, that's less interfering, because frankly, if you pick something that is very noticeable or very embarrassing for the patient to do, they're just not going to do it. And you also want to pick something that they can do for a little bit of a longer period of time. So it shouldn't be something that's painful or awkward, and it should also be something that they can apply in multiple situations. And that's simply because you don't want to have to come up with a competing response for every different situations that they might be finding themselves in. And once again, choosing a competing response is something that the patient and I decide together. So typically, we talk it through, we discuss the principles that would go into designing a competing response, and then we talk about what we might want to try. I might then demonstrate to the patient what I think they think the competing response is, and we might go back and forth a little bit before we agree on this is a competing response that we are going to try this week. And then we are demonstrating the proper implementation. I first demonstrate it to the patient, then the patient does it for me. And the idea is, of course, that this competing response will be implemented contingent on the tic, or even better, contingent on the warning sign. And then the patient engages in the competing response, and then they hold it for at least a minute or until the urge goes away, whichever is longer. So you want them to be able to hold it a little bit so that the urge can subside during the period while they are holding it. And here I just wanted to show you some examples of competing responses. So for example, if your patient has a leg tic, right, if they're moving their legs, they could place their feet flat on the floor and push their feet downward. Or if they're standing, they could lock their knees. Or Dr. Passantini talked about how common facial tics are, or mouse tics are so. So here what you can do is you can ask your patient to clench their jaw while they are pressing their lips together. Or for nose movements, you might pull the upper lips down a little bit and then press the lips together. Now, patients often, or not often, they sometimes engage in obscene gestures. That's actually not a very common tic, but if your patient has a tic where they want to give somebody the finger, for example, what you could do is you could ask your patient to make a fist, or even push the elbows into the side while they're making a fist, because while you're making a fist, you can't engage in that gesture. People often ask me about vocal tics. I think vocal tics are somewhat unfamiliar for many therapists to deal with, but they're actually not that hard to treat. And what you keep in mind here is that you can always ask your patients to breathe diaphragmatically, to breathe calmly. And what's important is that you keep in mind how the air flows during the tic. So for example, if your patient engages in a tic that pushes the air out, like for example, right? So I just pushed the air out, then your competing response would involve inhaling, right? Because the competing response is supposed to be opposite to the tic movement. Now, I earlier talked a little bit about social support, and I said that it's really useful, especially for younger patients. Even for adults, you can think about a social support system. I often actually invite family members in if they are very involved in criticizing the patient. So in that case, it would be really important, for example, if a spouse is always nagging, in that case, it would be really good if they could come into treatment. But especially for children, I think it's very helpful to have a support person because they can remind the child, they can remind the client. And as they're reminding the client, keep in mind that that needs to be done in an encouraging tone. So you don't want to be like nagging or punitive. And what the support person can also do is they can praise the use of the exercises. So they can be the cheerleader. And once again, it's the use of the exercises. It's the use of the tic management strategy, not the reduction of the tics that's being praised. And then at the end of treatment, you want to do relapse prevention. So what we typically do here is we often spread the last few sessions out a little bit. So for example, what you could do is you spread the final 2 sessions about 2 weeks apart. And then let's say you met with your client every Tuesday afternoon at 4 or so. During the week when you and your patient don't meet, the patient could actually have a self-session where they're going through all of the treatment strategies that we all just went over by themselves or with their parent if they're a child. So they could basically have a self-session during the off week. It's also very helpful to have booster sessions at the end of treatment. So the way you want to think about that is that, you know, after treatment ends, after your regular sessions end, you could still have a booster session maybe 1 or 3 months after the end of treatment or 6 months after the end of treatment, just again to review the strategies, to think about what's going well, are there any symptoms that have reoccurred, how do you want to address them, and so forth. Also, what you want to do at the end of treatment is you want to address overly optimistic or negative thoughts about treatment termination. And now that brings us to the last part of our module today, and that is cognitive behavior therapy for OCD. So once again, even when working with OCD, you want to start with a good detailed assessment. So you want to learn about the comorbidities that the patients might be struggling with. It's really important to learn about the impairment that may be related to the OCD. So for example, if you're working with a patient and the patient ritualizes so much in the morning that it's hard for them to get out of the house and they're always late for work and they might be at the verge of losing their job, it's really important to know about that as a therapist, because then you want to make that an early treatment target, and you may not want to worry as much about the OCD symptoms that occur later in the day. You obviously want to learn about current and past treatments. Once again, motivation and readiness for change is important. You want to learn about that so that you can apply motivational strategies as needed. And you also want to set some treatment goals. And you also want to figure out, what is my patient afraid of if he or she does not engage in rituals or avoidance behavior? What are their feared consequences? So that's basically what you cover in the initial assessment. Here is just an overview of what the treatment in general might look like. I already talked about the intake assessment. The treatment here, you can see, is often a little bit longer than what we do for treatments for Tourette's. The published studies, they vary quite a bit. They often are somewhere between 12 and 22 sessions even. But as I said before, when we talked about tics, you have to use your own judgment a bit. And some patients are more or less severe, and that would, of course, also determine the length of treatment. Sessions, once again, are 60 to 90 minutes. Adults often participate just as individuals in treatment, but if you're working with children, especially younger children, just like in working with tics, it's very, very helpful if family members can participate. And in OCD, it can be very helpful to have family members participate as well, especially if they're in some way intertwined in the OCD, if they're participating in rituals or if they accommodate excessively. It can also be very helpful to invite family members, even when working with adults. And once again, the treatment is a very collaborative effort where the patient and I decide on the exercises together. Here's an outline of what the treatment looks overall. You start with a detailed assessment, you do psychoeducation, you might do cognitive strategies and mindfulness, and then most importantly, you do exposure and response prevention. As I said earlier, that's the most well-studied intervention for OCD, and then you do relapse prevention in the end. So let me tell you a little bit about how we conduct psychoeducation with patients with OCD. So this is actually from a real patient of mine, and she had thoughts about stabbing her baby with a knife. She was a very nice young mother, but she had all of these intrusions that kept coming. And I should tell you that I'm a mother too, and when I had my first child, I often had strange thoughts like, oh, what if I dropped her or something like that. But when I had thoughts like that, I would think like, oh, what a weird thought. And I would just kind of forget about it and move on with my day or with my life. And that really wasn't true for my patient. So when my patient had these thoughts, oh, what if I stab my baby with a knife, for example, she would really attach a lot of meaning to this thought. She would think like, oh boy, I'm at risk for losing control. If I have a thought like that, that means I want to do it. Good mothers don't think like that. And those kind of interpretations made her feel really bad. So she felt really anxious and guilty for having these kind of thoughts and very, very ashamed. And then she engaged in all kinds of safety behaviors in order to regulate her anxiety and guilt and shame. So she would, for example, avoid all kinds of knives and sharp objects. She would keep checking over and over again if the baby was okay. She kept asking her husband for reassurance over and over again. She would ask him, am I a dangerous person? Is it safe for me to be with the baby? Things like that. She would pray excessively to ensure that nothing bad would happen. And while those behaviors really helped her short term, so short term she felt a sense of relief, right? Short term she felt better. On the long run, these were exactly the kind of behaviors that actually kept her OCD going, because she never realized that things would have been just fine if she wouldn't have ritualized or if she wouldn't have avoided, right? She never even tried to just tolerate her anxiety and not engage in safety behavior. So it's just like, I think you see the parallels to the premonitory urge and the tics that we just went over as well. Anyhow, so after you have done a little bit of psychoeducation with your patients, just like I did with you just now, you might engage in cognitive strategies. Here's an example of what that might look like. So here's an example of a thought form. So this is a patient. Her situation is that she's holding the baby. Her intrusive thought is, I'm going to smash the baby's head against the wall. Her interpretation is, if I'm thinking I'm going to smash her head, I'm actually going to do it. And then you can use cognitive interventions, and you can ask questions like, well, what's the evidence that this thought is really true, right? What's the evidence that just because you are thinking that you might smash her head, that you're actually going to do this? How many times have you had the thought that you're going to smash her head against the wall, and how many times did it actually happen? Can record the patient's anxiety too. And what's most important here as you're doing these cognitive interventions is that you use them in order to formulate a rational response. And here you can see an example of a rational response. So it would be something like, well, this is just a thought, and I've had this thought over 1,000 times, and I've never acted on it. This shows me that thoughts cannot cause action. So basically the idea here being a thought is just a thought. It doesn't mean anything much. So this is an example of a cognitive intervention. You can also do mindfulness or acceptance-based strategies. That basically means that you teach your patients to just let their thoughts come and go naturally, so you don't interfere with the thoughts. And I often give a metaphor when I use these mindfulness-based strategies, and I say, well, basically, just think of your thoughts like as if they were leaves on a river, and you're standing there and you're just observing these leaves on the river, and they're just floating by, and you sort of observe them, but you don't do anything about them. So you don't try to control them in any way. Or it's like, if you want something that's a little bit more intense and leaves on a river, you could maybe give them the image of a train going by or something like that. And they're just standing there and they're watching it, but they're not trying to control it. So that's the process that they're aiming for with their thoughts, to just accept them, but to not interfere with them, to not control them. And then, as I said, one of the really important strategies in OCD treatment is exposure and response prevention. And that strategy involves a number of different steps. So first of all, you help your patients identify triggers for anxiety as well as avoidance behavior. So that could be certain situations that scare them or certain places. And then you help them identify the rituals that occur around those situations. So how often do they engage in a ritual? How much time does it take up? How frequently does it have to be repeated, and so on? And then you design a hierarchy where you get a sense of which are the situations that are most anxiety-provoking, least anxiety-provoking, and so on. And then you actually conduct exposure and response prevention. So let me break that down for you a little bit further. So this is a real patient. And she has contamination fears. And what you can see here is her hierarchy, right? Her exposure and response prevention hierarchy. And so on the left, you have a number of different situations that are distressing for her. And then you can see a distress rating as well as an avoidance rating. And you can see here at the top, touching door handles, for example, or elevator buttons on a scale from 0 to 100 is, well, somewhat distressing, maybe moderately distressing, about a 45, and she avoids this quite often. But if you go at the very bottom here, you see using public bathrooms. That's extremely distressing for her. So she gave that a rating of a 90, right? And she avoids that all the time. Right, so this is what you want to do at the outset. You want to make a hierarchy like that so that you get a sense of how you want to plan your treatment. And then, here it is, you also want to get into the rituals as a next step. Many patients can actually just tell you what their rituals are. It's for many patients, it's easy to just tell you what it is that they're doing in order to counteract the anxiety or distress. But just in case your patient has trouble with that, you can use this ritual monitoring form here, where you keep track of what a particular ritual is, what it's triggered by, what kind of thoughts and feelings are associated with it, and how much time they're spending ritualizing. And let's say for Sarah, we identified rituals like excessive hand washing or the use of hand sanitizer or changing her clothes over and over again. What you can see here on this slide would then be a very good ritual prevention plan for Sarah. And you can see how detailed we are with her. So there's basically no contact with water except for one 10-minute shower, and you brush your teeth a couple of times a day, but only for 2 minutes, and you can wash your hands after using the bathroom, and when they're visibly dirty, you don't use hand sanitizer, you don't change your clothes, you don't ask your family members to change when they come into the house. And you can see how detailed this is, but it's important to be that detailed because often, especially when patients have had OCD for a long time, they lost touch a little bit with what's normal, actually. And now I want to get back to Olivia. She is a young mom we were talking about just a few minutes ago, the young mom with the harming fears, the lady who was afraid that she might be hurting her baby. And you can see what her exposure and response prevention hierarchy might look like. And here in this case, I wanted to put it all on one slide for you. So what you can see here on this slides are both the distressing situations as well as the ritual prevention strategies together, so you get an idea of how you might combine exposure and response prevention exercises. And here at the top, again, you can see that, buttering bread, for example, while being alone and not praying is somewhat distressing for her. But at the bottom, holding her child, holding her son or daughter while they're sitting on her lap, while cutting fruit, and not asking the husband for reassurance and not asking the husband to even check on them is extremely distressing. And it's something that she would avoid pretty much all the time. And then there are all kinds of situations in the middle that would sort of be intermediate steps for her to tackle. And once you have a good sense of how challenging certain situations would be for your patients, then you basically start exposure. And I very often like to do that actually in the session with me. We typically begin with an exposure to a situation that provokes moderate distress and avoidance. So basically a rating near 40 or so as a distress rating. Because, if you take something that's too easy, there's really not that much to gain. And if you take something that's too hard, your patient might just refuse to do it. And then over the course of treatment, you basically just keep working your way up the hierarchy. Again, you want to be pretty flexible. Situations also change in terms of how difficult they are for your patient as they go through the treatment. So you might have to have them re-rate the situations as you go along. And as always, you really want to make your patient an active participant in deciding what kind of exposure and response prevention exercises you want to tackle next. And the kind of exposure and response prevention exercises that you do are really only limited by your own creativity and by your patient's creativity. You often find yourself actually leaving the office as you're conducting this treatment. And then relapse prevention is pretty much what I was just already explaining for the treatment of tic disorders. So again, you might want to fade out the sessions. You don't want to end the treatment too abruptly. You want to have booster sessions, review the strategies with them towards the end of treatment, gives them a sense of what they might do if their symptoms recur. So initially, if their symptoms recur, they might just sit down with themselves and have a self-session, but if it gets really severe, they might just need to come in for one booster session or so. They may not necessarily need to have a full course of treatment, and that might get them back on track if they just have one booster session with you. And, well, thank you very much for your attention, and now I'd be very happy to answer any questions that you might have.
All right, thank you, Dr. Wilhelm. Here's this question. You covered a lot today, but I feel that I would need more training before I am ready to conduct these treatments with my patients. Can you recommend some additional resources for both CBIT as well as for learning about CBT for OCD?
Okay, sure. I'd be very happy to do that, and that's a great question. So there are actually many different resources for you. So, for example, for Tics, we wrote a treatment manual that's called Managing Tourette Syndrome, which I would recommend. It covers CBIT in great detail. The first author of this treatment manual is Douglas Woods, and I would also strongly advise you to go to the website of the Tourette Syndrome Association. So that's www.TSA, I think it's www.tsa-usa.org. And if you go to that medical tab, you can find out what kind of trainings the TSA is putting on in the near future. They have a wonderful training opportunity. It's called the Behavior Therapy Institute. It's a 2-day training where people who want to learn CBIT can really learn it in great details and will be able to apply it afterwards. And actually, there's a conference coming up in the very near future. So if you really want to travel and really want to immerse yourself, you could travel to London and I think it's June 24th, where there's a whole conference on Tourette syndrome where CBIT will also be covered. And then for OCD, there's also a very nice website. It's a website from for the International OCD Foundation. Oh, and I just see you put up the slide, Nancy. So it's the IOCDF website. So I would definitely recommend that you check that out. They also advertise Behavior Therapy Institute, where you can conduct a train or learn or go through to a training that's going on for several days. It's really wonderful, and you really learn the treatment. There's also many treatment manuals for OCD that you can choose from. There's so many. I mean, John Abramowitz, for example, wrote an excellent one. Edna Foa has one. I wrote one. Gail Steckedy wrote one. So there are many treatment manuals, and they're all good. I mean, so you could really choose any one of them, and I think they would help. And then you could also go to the Mass General Hospital Psychiatry Academy. That is mghcme.org, and we have many courses on CBT in general, and one for OCD specifically that's going to start in September. It's a 4-week course, an online course, if you like online courses, where you can also learn the treatment of OCD really from the beginning to the end.
Great, thanks. A lot of resources available for folks.
Yeah.
Wonderful. You make ritual prevention sound easy, but what do I do if my patients cannot give up their rituals cold turkey, and that's in quotes? Are there any intermediate steps I could suggest?
Yeah, that's actually a really good question because, like you said, it's really hard for many patients to just stop. Obviously, we would like for that to happen, but for many patients, it's just not possible. So you often actually end up picking your battles as a therapist, and you and your patient to agree to only address certain situations, to only address certain rituals, and you might leave others untreated for the time being. And actually, gave you a bit of an example earlier as we went through the presentation. Remember I said that, for example, if you have a patient who might be at risk of losing their job because they're always ritualizing in the morning and they can't get out of the house. So that would be an example of really picking your battle. So you are just working on those rituals for a while, those rituals that occur before leaving the house, and you might leave the other ones that occur later in the day for the time being. You also do what we call watching the clock. I use that strategy all the time. So, for example, if somebody has a ritual that always goes on, that has to be repeated, 20 times every time, we might be able to cut that in half, or we might at least be able to change the number. So basically what we do in therapy is we negotiate a little bit as therapists. We negotiate a little bit with our patients, and we take what we can get. And, you know, the more they're willing to give up, the better, but they might not be able to give up everything. So, you know, so for example, if a ritual takes half an hour at first, we cut it down to 30 minutes. Or if something is repeated, if something is repeated 20 times, we cut it down to 10. We also use competing responses in OCD treatment, so that's another, just like in Tourette's. So you're basically changing the nature of the ritual a little bit in terms when you're making it hard to occur. We've actually postponed rituals. So, for example, if your patient is not really willing to give up a ritual completely, you might say, all right, well, why don't we postpone the ritual, let's say, for half an hour, and once a half hour is over, you postpone it again for another half an hour, and so on, again, in order to recommence the ritual. So we have some tricks in order to make ritual prevention a little bit easier if the patients are not willing to give it up, their rituals up completely right away.
Thank you. We have time for one more question, and it'll be this one. For the functional behavioral analysis of tics, do you use a self-report or parent report questionnaire, or an interview or observation?
Mm-hmm. So what I tend to use is actually a worksheet that is in the Managing for Tourette Syndrome book that I already mentioned earlier, and it's a worksheet that basically helps the patient and I go over antecedents and consequences for each tic. But frankly, you could make that up yourself just by really taking each tic and asking your patient what's happening before the tic and what's happening after the tic in an interview fashion. I mean, you could do it in a self-review way, a self-report way, but I think it's very nice to do it in an interview fashion, because that way the patient and I can go back and forth and I get a better understanding of what's going on.
Thank you, Dr. Wilhelm. Real quickly, I just want to get one more in here. If a patient has other problems, such as depression, do I need to treat the depression first, or do I treat the OCD or tics first?
Oh, that's a really good question. It's about sequencing of treatments. I guess I'd say it depends. So let's say you have a patient who has really severe depression, right? And your patient has no energy and they're not motivated. Then I think it would be very hard for them to engage in tic management strategies or in treatment strategies for OCD. So in that case, I would treat the depression first. But let's say things are a bit reversed and your patient is depressed because they're so unhappy about having OCD, or they're so sad about having to deal with these tics all the time, and the depression is relatively mild. In that case, what we often see is once we treat the tics or once we treat the OCD, the depression actually improves on its own. So I guess I would say it depends on the severity of the depression and also on how we conceptualize it and what we think, what causes what.
All right, and that does bring us to the end of our time, but I thank you so much, Dr. Wilhelm, for this wonderful presentation.
Thank you. It was a real pleasure. Goodbye.
Goodbye now. And for the folks still online with us, please remember to click on the survey link here. Help us out by answering a few questions, making some suggestions perhaps for future webinars. And on behalf of the Tourette Association and the International OCD Foundation, thank you very much for attending today's program.